those as much as we can in between. If I have to, I'll just save the answers for the end. And also, we're going to save the questions and answers for the end as long as we have time. And I don't see why we wouldn't have any time. So without any further ado, I'm going to hand it over to Rebecca.
Hi, thank you, Gloria, for that introduction, and thank you to DDAP for allowing us to do this presentation today. I also wanted to thank both Kevin and Daniela as we're going through the presentation for joining me on the panel. So I'm going to start off with some introduction on treatment for methamphetamine use disorder or stimulant use disorders, and then Kevin and Daniela are going to be speaking about contingency management a little bit more in depth. So Gloria, oh, there we go. My slides are loading. So let's see. So the first thing I'd like everyone to take some time to consider is if you are a counselor at a local SUD agency, during an initial assessment, a new client tells you that they're using methamphetamine. So what would you do in terms of engagement, treatment, and management? Just take a couple seconds and think about that. Okay, great. Hopefully you were able to come up with some thoughts, and if not, hopefully this presentation will help you with thinking and formulating steps for treatment. So the first thing you would do in terms of engagement is do some psychoeducation for your client. And so you would want to talk about the neurobiological effects of the methamphetamine use. And when you're doing that, you would talk about how it decreases your immune system, increases the risk of Parkinson's disease. There's an increased risk of stroke, decreased motor memory, decreased verbal memory, and nerve damage. And it's important to not only give your clients this information, but go into a little bit of depth as to what these different things are and the process that it takes. So although the person may not immediately experience some of these symptoms, it could progress over time and really impair someone's ability to function. The next thing you'd want to talk about are the emotional health effects. And so you're going to talk about psychosis and really talk about the paranoia, audiovisual hallucinations, and delusions. And one thing that you'd want to point out is that it can be ongoing for years, and even after the use stops, it could return as a stress reaction. So the sooner someone stops using, the less likely it would be to experience these symptoms long term. The other thing to look at is the mood symptoms of the significant anxiety. There's confusion, insomnia, mood disturbance, and violent behavior. And I did want to point out for all of my slides, I do have the sources cited at the bottom through links. So if you get a copy of the presentation or you'd like a presentation, you can email me for it and I will give it to you and give you access to all of the articles that I used. And the poll question's up, so if you could take some time to just take a couple seconds and answer it, that would be terrific. You also want to talk about the physical health effects and talk about weight loss, dental issues, and skin sores that people experience from amphetamine use. And then the last thing that you'd want to do in terms of psychoeducation is review behaviors. You want to, and it's not enough to just say, okay, we're going to make a list today of all of the risky behaviors that you've done. Yes, you want to start there, but that's not how the conversation should end. Not only are you identifying the risky behaviors, but you're also going to discuss risks associated with those behaviors and then discuss how to establish replacement. The important thing to note is that when people stop using substances, they don't know how to structure their time always. And so they have those old habits that they've had in the past and the habits associated with using. And if they don't have replacement habits, they're going to go back to what they know instead of how instead of not using. And so when you're looking at those replacement behaviors, you're teaching them not only what they should be doing, but allowing them to practice other things that they can do. So their day isn't structured around using or obtaining the substance. Their day is established with maybe going to treatment, attending meetings, talking to family, taking their medication, going to sleep and waking up at the same time every day. You want to really help them establish new healthy habits. So then when we're looking at treatment that works, it's evidence-based. There are 5 different evidence-based treatments for stimulant use disorders. We do have contingency management on the top. That has been the most effective for methamphetamine use. And Danielle and Kevin will talk about that a little bit more in depth in a couple minutes. We also have the matrix model, community reinforcement approach, motivational interviewing, and cognitive behavioral therapy. Just have a couple slides on each of them, or one slide on each, just to go over some of the high-level points of what this each are. So with contingency management, what they're looking at is positive reinforcement for behavior changes. They're determining the monitoring benchmarks. Rewards increase as behavior is sustained, and then determine the rewards for benchmarks. You can see here there's a study that was done, and they found that the contingency management did much better than people who did standard care. Additional information on literature reviews for contingency management, 2 other studies were done, then showed that contingency management was the most effective than any other form of treatment that was done compared to. Looking at the matrix model, you're looking at a strong therapeutic relationship. It really teaches people how to structure time and establish patterns, which we talked about a couple of seconds ago, providing educational withdrawal and cravings, going over relapse prevention and coping techniques. And it's not only talking about relapse prevention, but it's helping people practice the relapse prevention and practice new coping techniques. Looking at family involvement, we just heard earlier this morning how important family involvement is, and the matrix model does have that as a component of their structured therapy. Also encouragement of community-based mutual support programs, and then random substance use screenings. The community reinforcement approach looks at the functional analysis of substance use, the sobriety sampling, and it really takes a look at using the happiness scale as part of developing the treatment plan. The happiness scale, it's 10 questions, it's evidence-based, and what it is it has 10 different items on it, and it has a person rate on a Likert scale how happy they are in each of those domains. There's also behavioral skills training, job skills training, social and recreational counseling, relapse prevention, and relationship counseling. Once again, tying into that family approach and making sure that people that are supportive of recovery are involved in treatment. And when we talk about family, we're not necessarily talking about a biological family. We're talking about the family as people who are identified by the person in recovery as someone that's a recovery support. May or may not be biological. Motivational interviewing really helps people through that change process. The people in services are identifying their desired change and reasons for changing, not the practitioner. That's pretty important to note, that we really want to help people determine and hear themselves say why it's important to make that change, not always for us to say that. And also it addresses ambivalence. And there's 5 principles involved with motivational interviewing. Expressing empathy through reflective listening, develop the discrepancy between person's goals or values and current behaviors, avoiding argument and confrontation, adjusting the client resistance rather than opposing it directly. So instead of, we heard this morning also about tough love, and motivational interviewing kind of combats that and says, no, we don't want to do that. We want to help the person develop that desire to change and make sure that we're encouraging them and supporting them through that process instead of telling them how it needs to be. And it also supports self-efficacy and optimism. And then the last is cognitive behavioral therapy, which combines the thoughts, feelings, behaviors together and helps a person develop an alternative response that would help them stop using. Sometimes a couple of these techniques are paired together, and there has been a lot of effective results from the pairing together. And looks like we've got almost everybody has responded to the poll, so great. The last thing is management of symptoms. And so some pharmacological approaches are being looked at. You can see here medications that have been attempted, but there's really, as we've heard throughout the past 2 days, not much that is available for MAT, or not a lot has been completely effective for managing symptoms. These are different medications that providers have tried and have had some impact, but nothing that was really solid as a recommendation has come out yet. So just some things to keep in mind, that some medications may help decrease or alleviate some symptoms, but not completely control them. And then also, whenever you're working with someone with a stimulant use disorder, you want to make sure that you are also taking into consideration the co-occurring mental health concerns. And all of these are diagnoses that could be co-occurring for someone with a stimulant use disorder. So you want to make sure that you are treating the person as a whole and looking at how their mental health could potentially impact their substance use, but also how the substance use could impact the mental health. And then also looking at physical health conditions that are associated with stimulant use disorders. You want to, we heard a lot about over the past 2 days about opioids and stimulants used together. So really want to make sure if someone's coming to you with chronic pain and using stimulants, that you help address that so that they're not at risk for an opioid overdose in addition to the stimulant use. Also addressing HIV, heart disease, and cancer. And then the last thing that you want to look at too is the social determinants of health. And these are the people, if someone falls into these categories, are at a higher risk for stimulant use. So an annual family income under $20,000, participating in government assistance programs in the past year, not working in the past year, residing in a small metropolitan, non-metropolitan area, so more of those rural communities, and the health status is good, fair, or poor. Here's my contact information if you have any questions. Be more than happy to take them either now or at a later time. Otherwise, we could pass it to Daniela and Kevin and take all questions at the end. Thank you.
Thank you, Rebecca, very much for your presentation. And we'll just go ahead and answer the poll question real quick since we have a little time. The answer to that poll question was how many people used stimulants in the past year. Let's just see. I wanted to bring the poll up. It disappeared. But the answer was over 2.5 million between cocaine, methamphetamine, stimulant prescriptions. That totaled to over 2.5 million. So there we go. According to Sampson, the United States in 2018, how many people aged 12 and older had a methamphetamine, cocaine, stimulant use disorder in the past year? And it's a lot more than what we would think with all of those combined, over 2.5 million. Thank you. So without further ado, we will turn this over to Dr. Kevin Moore.
Good morning. As we're getting this slide set up, I'll just introduce myself. My name is Dr. Kevin Moore. I'm Director of Integrative Medicine at Crossroads Treatment Centers. There's a slide saying a little more about the specifics in a moment. I've been working with people with stimulant use disorder and opioid use disorder and other things for 15 years, but very happy to talk with you about our partnership, about Crossroads Treatment Center's partnership with WEconnect today. Actually, Daniela, do you want to sort of preface this a little bit before I say to the next slide or two?
Sure. Hi, everybody. I'm Daniela Luzzi-Tudor. I'm CEO and co-founder at WEconnect Health Management. Really grateful to be on this panel today with Dr. Moore and Rebecca. This partnership occurred last year between WEconnect Health Management and Crossroads. It was in partnership through a health plan in the Pennsylvania area, and Crossroads was our largest partner in this particular pilot. So I'm really excited for Dr. Moore to take it away and tell us a little bit more about Crossroads and how WEconnect Health Management partnered in the market and some of the
Daniela,
yes.
I apologize for interrupting, but people are having a trouble hearing you. If you can adjust your microphone.
Can you hear me now? Is that better?
If you click the volume arrow right next to the microphone, you can adjust the volume in there.
Did that work? Can everybody hear me now?
I can hear you fine.
I can hear you fine.
I can hear you.
Okay, great.
Yeah, we're getting feedback that that's better.
Okay. As I mentioned, I'm Daniela Tudor. I'm the CEO and co-founder here at WEconnect Health Management. In the last year, we had the pleasure of partnering with a local health plan in Pennsylvania, and the largest provider that we had the pleasure of partnering with in that partnership was Crossroads Treatment Centers. And this was actually a great opportunity for us out in Pennsylvania to partner with partner that does medically assisted treatment as well as some additional behavioral health services. And Dr. Kevin Moore will share more about that and how we partnered with them.
Thank you, Daniela. Can we go to the next slide, please?
Thank you, Daniela. Can we go to the next slide, please?
On my own microphone.
I'm getting feedback on my own microphone.
Oof.
Try it again, Dr. Moore.
I can't hear myself, so that's good for me if that works for you. So we've done introductions, and then this is briefly what we're going to talk about. And now I'm getting feedback again. Can we advance the next slide? And the next one. Great. Crossroads Treatment Centers is focused on opiate use disorder primarily. We are a medication-assisted treatment of opiate use disorder, what a lot of people call OBOTs, Suboxone clinics, and so that's our focus. We are the largest provider, to our knowledge. We're the largest provider of buprenorphine, also survivor of buprenorphine treatment in Pennsylvania. We currently operate over 42. We're opening 43 centers across the state. We serve now 12,000 patients, a little bit over that now. Yeah, there's the exact number right there. We were looking at expanding how we can better serve our patients, and we were looking at digital therapeutics. And WEconnect, as Daniela had said, was an exciting option for us in terms of helping our patients who, often increasingly have stimulant use disorder issues in addition to opiate use disorder, and it is because we do not have an equivalent medication like buprenorphine or another type of medication-assisted treatment for stimulant use disorder. We were very eager to look to see how this partnership could assist us with this additional problem that so many of our patients have. And so we did this pilot last year. Next slide, please. These are the states that Crossroads is operating in currently. So we have a very broad experience with, again, with opiate use disorder primarily, but we know that stimulant use disorder is the second highest incidence of diagnoses among our patients, and we're eager and desperate to move towards evidence-based solutions for this issue. I'm glad that the next poll question has come up. I was about to cover this information. Glad that I didn't, and that we can have the audience vote on that first. Next slide, please. So our model in focusing on opiate use disorder is a low threshold for induction. There has been an evidence base showing that buprenorphine is widely effective to the vast majority of people with opiate use disorder, and that it's the gold standard for treatment. And so we focused on trying to get people access to this as sort of job number one. There has not been, certainly there are other agencies that are trying to do what we're doing, but in general, there is not widespread access. There's not a lot of agencies that are trying intentionally to work with as many people as possible, including people on Medicaid. And so that really has been our focus across the 10 states you saw on the last slide. So yeah, we're looking to improve that, to improve adherence, to assist them in their recovery in many ways. Next slide. So when we were trying to figure out what we could do, certainly motivational interviewing, cognitive behavioral therapy, community reinforcement, the approaches that Rebecca had covered before this section of the presentation, we were certainly trying to get access for our patients through local resources, as well as we are now building our internal resources to do that. But we knew that we tried to manage the health of a number of people with homelessness, and we didn't know how accessible a phone app platform would be to our patients. So we did an internal survey and thankfully found that, in fact, 97.5% of our patients did have access to a cell phone, including people that were experiencing homelessness or were having housing insecurity. And so we felt very confident that this, in fact, would be an ideal platform. Now, this was all before COVID hit and everything became a virtual tele-world and so on. But at the time, we didn't really know that. And so, having found that internal information, we then looked for partners. Next slide, please. And Daniela is going to talk about how our pilot went. I'll just briefly say that we were very pleased and found a lot of success. We found an increased, not just adherence to medication, but increased maintaining in care, which of course is sort of our top concern, that we can not just give people access, but can keep them, support them in their journey to be maintained in the recovery process. Daniela.
Thank you so much, Dr. Moore. So if we could go to the next slide, we'll dive right in. So Rebecca actually touched on these points as well, but bringing it back to the issues that people often encounter when they're experiencing these different disorders and they're attempting to get into some pathway of recovery. I just want to share that in addition to being the CEO and co-founder of WEconnect Health Management, I'm also in long-term recovery myself. And when I went through a 4-week treatment program over 6 years ago, I encountered these different things that were going to be key to maintaining long-term recovery. And of course, through research, our data scientists, our product and engineering team, pulling all of that together with research, we found that these are the 3 core issues that people experience when attempting to get into recovery. So first and foremost, lack of human connection to not just their care providers, but the peers that they're surrounded by. Once I stepped out of that 4-week program, I realized I wasn't going to be surrounded by that environment, and I knew it would be key to extending recovery. Next, after that 4-week program, and this goes back to why programs like Dr. Moore's are so important, is lack of accountability. I was given a piece of paper that was my care plan, and it listed an exorbitant amount of things that I was supposed to complete, and I'm supposed to complete on a weekly or daily basis for the rest of my life to maintain recovery. And so looking at, and as Dr. Moore highlighted, that research that folks do have a cell phone with them 24/7, that could be something that could increase that accountability when you are back out in the world and trying to rebuild and build and thrive in life. The last thing was when I got out of that 4-week treatment program, I was supposed to check into my recovery housing, get to my outpatient appointment, and also go to a 12-step based community program. And I was feeling a lot of nervousness around that. And so I went through a Starbucks drive-through. I didn't realize my card had been shut off. And when I tried to hand back the coffee drink, the barista not only gave me back the coffee drink, but also gifted me a cake pop, which is only $1.50. But that sense of reward and positive reinforcement in that moment, I felt so much more comfortable going about my care plan activities that day. And I knew there was something to it. So shortly after, about 2 months later, as I started building the team and the company, we came across contingency management research, which is a core evidence-based treatment that is embedded into our digital platform. So if we could go to the next slide, that was my individual and also the people experience, what people were experiencing in trying to sustain recovery. But we also started looking at the overall system. So the challenge that we thought is with that long care plan that people often get and the different activities they have to engage in, it can feel really disparate, managing a calendar, trying to make the different appointments, and then remembering what is going on for that day. And so often people have multiple pathways and multiple things that they have to complete, medically assisted treatment, now with COVID, of course, telehealth, going to PCP appointments to take care of those chronic physical conditions that Rebecca highlighted in her presentation, group therapy, and just a number of other things. And so the brainstorming at that time was around how can we bring this fragmented world together for the person, so it makes it really easy to stay connected, accountable, and feeling that reward so they can stay continuously engaged in their program for the long term. So if we can go to the next slide, I can break down the WEconnect health management model. So there's 4 parts to it. First and foremost, as I mentioned, there's a patient-facing mobile application that has contingency management embedded in it. And then we also have our certified peer recovery support specialist that use a tool we've developed internally, a data dashboard where they can actually communicate with the member from the dashboard and also prioritize care for the individuals that need it the most that day. In addition to that, with the onset of COVID, we started online support meetings. These are free, but they're also embedded in the mobile application, so someone can see a schedule of those mutual aid meetings and they can instantly log in and participate so they can feel that connection. We actually just crossed a threshold with a number of partners that were engaging in those free online meetings of 300,000 people logging in since COVID has started, and that includes not just in the US, but also outside. So this is just highlighting the need for support, especially when stay-at-home orders are happening and people are feeling that isolation, which is a huge risk to someone trying to maintain recovery. I will also mention that as we get into the slides about the partnership with Crossroads, we were really fortunate. They have their own care coordinators that are also folks with lived experience often, and that was extremely powerful because not only did we have our peers assisting, but Crossroads has such a comprehensive model when it comes to really giving people what they need in addition to the medication. And that, I believe, was also a key contributor to making this partnership very successful. So if we can go to the next slide, we're going to highlight these different program areas. This is a snapshot of the mobile application. One of our investors is the CEO of a company called MetaLab, and they built the UI UX for big mobile app companies like Uber, Slack, Apple. And so we really thought about the design and the UI UX to make it fun and easy. In fact, we also leveraged a study from University of Washington that said across all demographics and all age groups, if you make a digital platform fun, easy to use, has animations in it, it's going to be more engaging, and they proved that through their study. So we paid really close attention to make it easy, fun, and engaging. At the top there is where contingency management is embedded. So as you go through the different what we call challenges in the application, which are made up of support routines that people engage in, things like going to their medically assisted treatment program, engaging with the care coordinator or peer, going to other types of community support meetings. They will earn for that particular challenge as they go along the incentive, which in this case was Amazon gift card. And you'll also see later in the presentation some of the feedback we've gotten from people earning those incentives. And so as they go along and they check into their different support and self-care activities, including the online meetings, and those are verified by both GPS. So if it's at a physical location, they can check into it. The app only in that instance checks that they were at that particular location, or an online URL. So if it's a telemedicine appointment or an online meeting, as they click into that URL, the application verifies it. And in that moment, they're able to earn the incentive and continue earning that. We also have recently released the wallet, and so they're able to instantly earn that reward and be able to purchase something with the Amazon gift card. The other thing I'll mention is that this is tied to social determinants of health. So we survey the population on what they've been able to use those incentives for, and often it includes things like household items, food, things like transportation, gift cards, and so for alternative transportation modalities like Uber or Lyft. And another thing that we've also noticed and have gotten tons of feedback on is that they'll purchase things for their kids. We've gotten some really incredible stories in that regard. We also have one member that gave us feedback that his car broke down. He was able to purchase the part for the car with the incentives he earned, so he was able to maintain his job. And so again, we tie all of this data back to social determinants of health in terms of what they're engaging in and addressing some of those issues that Rebecca also highlighted in her presentation. We could go to the next slide. I'll highlight a little bit about our data dashboard that our peers leverage. So our peers have a roster of the different members. This can also engage if that particular partner has other folks on their side that is checking the dashboard. So in the case with Crossroads, their care coordinators are able to view this. We're able to view this dashboard and prioritize care. We've built a patent pending risk score algorithm that takes into account the length of someone's date of self-reported recovery, as well as their engagement in the application support routines. So how many appointments did they go that they scheduled in app with their care coordinator, and it pops out a risk level. And so they're able to see when they go into that patient record, what activities they engaged in, what activities they didn't. And then they can message the member from this dashboard and say, hey, it looks like you might need some additional support with scheduling, or why is it you didn't make it to that appointment? How can we help you and support you? Again, everything is with positive reinforcement is the mindset and the approach that we take. In addition to that, if there are particular appointments or support routines that need to be embedded into the person's mobile app, you can schedule those out of the dashboard and they'll pop up into the individual's WEconnect mobile application. Next slide, please. So this brings us to some of the results we had in this partnership, and it's really exciting. If we could go to the next slide, we can dive right into some of the workflows and data that occurred within this partnership. So I know you all will have access to this presentation. I won't go through every single step of the way here, but essentially, again, we embedded ourselves with the care coordination team at Crossroads, partnered with them, and there's different levels of engagement that the member can engage in. And so once the individual is set up on the mobile application, which takes a few minutes, we actually embedded some of our staff at those specific clinics, coordinated with those care coordinators. And if the member wants to continue and use the app to engage in those support routines and just wants messaging, they can continue down that path. If they want additional services, our peers can also engage in recovery capital planning, which is extended over 3 different tiers. So one is that level of messaging, which the Crossroads care coordination team really monitored and engaged with the members through the messaging platform built into the app. If they wanted additional services and create a recovery capital plan, they can do that, and we can assist those members with video, telephonic assistance, and create a true recovery capital plan around their social determinants of health, around different goals they have in life outside of that. Those types of routines can also be scheduled in the app, so things like court dates, appointments for shelter, any kind of financial assistance programs, and they can get credit for those in addition to their clinical care plan to engage and be able to sustain all of the different aspects of their life that they need to stay accountable to in order to maintain recovery. So next, we're going to take a look at a particular member journey and why this program of engagement, along with Crossroads' robust services, is really key. If we can go to the next slide. So Jessica entered her journey into recovery. As I mentioned in the previous slide, she was able to set up appointments on the app, and in the dashboard, they were able to assess risk due to her missing a medically assisted treatment refill, and they were able to reach out and that she was actually just struggling with scheduling and being able to support her with that. And so she's able to stay on that journey. Without this type of partnership and without robust services like Crossroads, this is a point where people can fall off and get readmitted to the emergency room or have some other type of incident that exacerbates their condition and cause for the healthcare system and send them back to where they really need that support. And so if we go to the next slide, we can look at some of the data and results we saw. These results came as claims data from the health plan that we partnered with in the market. And so really excited to show that we were able to increase through this partnership visits to the primary care physician that were appropriate. So when Rebecca was talking about treating those chronic conditions, that's really important and key, that someone continues to go to the primary care physician and gets those things looked at. And then on the MAP prescription refill side, we had a 34.9% increase, which was really, really exciting to see through the work of Crossroads and the services that they provide, as well as our partnership in market. And then last but certainly not least, within the first 90 days, there was a decrease in emergency room visits. And so this was really exciting that in the first 90 days of this 12-month program, these claims from the health plan that we were partnered with show these types of results. We also look at month-to-month engagement. As I'm sure the audience knows, getting claims data back takes quite some time. So we want to be able to also show results immediately and month over month. And so if you go to the next slide, we measure engagement in the app, and we had these different targets with the health plan in market. So these included members being successfully onboarded, checking into those GPS verified routines. This was before COVID, where a majority of the routines were not telehealth. Percent of members that were engaging in those PCP visits, because this was with a health plan, they were looking at medical conditions, and so primary care physician visits were a preventative measure that was really important to them. And then we also survey the members where they can self-report abstinence from their substance of problematic use, receiving that peer and care coordination outreach, and then also them reporting their satisfaction with the platform. And as you can see here, month over month, we exceeded those metrics, and we were able to show that the app is engaging even before we saw an indication on the claims side from this particular health plan that we partnered with. So please go to the next slide. So these are some member testimonials that we got, which I get really excited about. This is what makes our work really meaningful. And if you go to the next slide, we'll just share a couple before we hand it back over for Q&A. This particular member said, over Christmas, I'm proud to say that I got my daughter's presents with the money that I earned working hard towards my recovery. Thank you with all of my heart. Next slide, there's a couple more quotes here. If it weren't for WEconnect and their team of peers like Michelle, I probably would have relapsed by now. At the beginning of my recovery, I was sleeping in my car, and now I'm in a house and my children are a part of my life. So this has real world impact in these members, and this is through the work, of course, of Crossroads and the comprehensive care that they provide, and then our ability to bridge that through digital, that connection, that accountability, and being able to incentivize them through the evidence-based contingency management work to continue to stay accountable to those activities that really help the member continue to get healthier and healthier and sustain that long-term recovery. So with that, we also have at the end of the presentation, of course, all of our sources. You can reference those and dig more into the research, the different things that we've referenced, and hope you take a deeper look at the set of slides, and thank you everybody for your time today. And before I actually hand it over for questions, Dr. Moore, is there anything else you'd like to add? Happy to hand it back over to you as well.
Particularly to add other than to say that
I don't have anything particular to add other than to say that
if what Dr. I'm sorry, Daniela, if you could mute your microphone while Dr. Moore is speaking. I think that's causing the echo.
now.
Sorry, this digital age that we live in. Thank you for that very comprehensive review, Daniela. I think you hit all the major points. I would just come back and say that for our care coordinators, whose job it is to link people with primary care, mental health services, other services that an individual may need, it was incredibly helpful to have the utility of WEconnect and to have that additional communication, additional care coordination to help our care coordinators do their job. They were more efficient. I mean, in addition to the data that you just showed, our jobs became easier, and we had more partnership, not just through WEconnect, but with the patients themselves. So I just wanted to emphasize your main point. Thank you very much.
Thank you very much, everybody, for your presentations. We're going to go back to the lobby view here, and we will review first we'll review the second poll question. That is not the second poll question, sorry. Ashley, do you have the second poll question there somewhere? There we go. Sorry about that. Oh, I'm sorry. Here we go. Over the last 10 years, the number of treatment-seeking individuals with opioid use disorder that reported using methamphetamine in the last month has actually increased by 50%. So that is a pretty large number. And I know this is not specifically for stimulant using individuals, but we do have a lot more people using stimulants who are on MAT. But let's go to some questions for the group. As soon as I can find them here, this is a little, takes a little, I know we have questions. Well, the
Gloria,
first question that I remember,
quick.
yes.
If you scroll back to the more tutor slides, the questions will show.
Oh, I see. Okay, I don't see the questions if I'm in the lobby. There we go. Thank you. Okay, the first question was, Did you run into problems with the Medicaid $75 cap on incentives? And I think this could be
Thank you so much. So the Medicaid cap actually does not apply to our program. I also have some references if the group wants from an OIG opinion, and of course the work we've done in Pennsylvania and now in several other states. And the reason for that is that the member is earning the incentive. It's not a gift. By engaging in those recovery plan activities, treatment plan activities, they are actually earning the incentive, and it's not a gift. And so that $75 annual gift cap is a gift that you would give just to give. But since they're earning it, that gift cap does not apply. Our programs range up to being able to earn $800 per year.
Thank you.
Thank you.
Follow up to that question is who is financially responsible for the payout of the incentive?
Yeah, so right now most commonly the health plans, MCOs, and we're starting to get into some engagements with EAP plans. They basically fund a bucket of the incentives in a trust, and so that's a pass-through that goes to the members.
Next question. Do you have opportunity for those who do not have a cell phone? This person's agency is seeing about 50% of publicly funded clients that have a cell phone.
Yeah, so in California, we encountered this. We work with an organization that serves primarily veterans that are just getting out of experiencing homelessness into their program. And what we did is we handed off a partnership with T-Mobile where they were able to get cell phones with a program on it that required them to engage in the application in order to maintain the mobile cell phone. There's also a government program that we can leverage that can provide mobile phones as well. We have not encountered the need for that, but it's always available if it's needed, and there's a set of steps that we can take in order to support the MCO, the health plan, or the partner that we have in market to be able to leverage that. Go ahead, Kevin.
The passing of the mics is
The passing of the
hard thing. Great. I was going to say, so one of the things that our care coordinators do is help people get public assistance, cell phones. That program works differently in different places, and because we're across the entire state of Pennsylvania, it's there's not a one consistent answer that we can give, but we definitely have utilized or helped our patients utilize those programs as part of this. So I can say that within Pennsylvania, this has been, as I said, a problem we've mostly been able to address.
Great. Next question is, how long does a participant remain enrolled?
So our partners typically pay for 12 months of engagement, so 1 year. And I'm sure most of the audience here knows that getting someone consistently to engage in a program for 1 year is really critical. And then we also do have inbound requests where people will self-extend the program afterwards, which was a bit surprising to us in a good way though. And so we're actually taking a look at what that would look like in the future. But for right now, it's 12 months in the partnership that the person will be funded by the partner. Of course, we're looking at different ways to extend that, but for now it's 12 months.
Okay, it looks like we have one more question. Are you still requiring patients to attend substance use?
I'll take that question. Formerly, sort of during the time of this pilot, Crossroads did have did have a requirement for treatment, but we, as evidence continues to come in, researching our low threshold model, we really found that that not requiring that was beneficial. We had a change in our policy kind of during the time of the pilot, where we no longer require our patients necessarily. We strongly encourage it. The care coordinator's job is to connect them. We actually have built in our capacity to have telehealth access to psychotherapy within our service, but we do not require it. The recovery routines that Daniela talked about are self-determined. The individual, the patient, is the one who says, here are the things that I need to be doing on a weekly basis, and here are the things that that I need help being held accountable in doing for my own recovery. And so while our care coordinator would encourage therapy to be part of that routine, that was not required. I also wanted to just jump back to the last question and say that we actually I went straight out of my mind. I'm sorry. What was the last topic? I had one point that Daniela, you just answered.
I believe it was how long does someone remain enrolled?
Thank you. Yes, thank you. I appreciate it. So part of why we were excited about WEconnect is many of the other applications that we were looking at, trying to work with, were generally 90 days. And while the initial 90 days after someone becomes a patient is very critical, recovery is a long-term process. And so we found the year, while it being even longer would be even more helpful, we found the year to be a very, I don't want to say sufficient, but definitely a step in the direction that we're trying to go. So this is 12 months is actually a very long time relative to sort of industry standards.
It looks like that was the last question. And I just want to thank all three of you. You did a magnificent job. I'm sure on behalf of everyone listening and who was able to be part of this presentation, we thank you very much. This session was called Thinking Outside the Box for treatment and recovery programs that unwrap new possibilities. And you definitely think outside the box, and we need more of that in our field. So thank you very much, and I wish all of you a wonderful day. Yes.
We actually had one more question come in right when you're switching the slides, so I just pulled that back up.
Sure. Let's see here. For Dr. Moore, isn't counseling required by the state of PA? How were you able to work around that? And you didn't indicate this is an OBOT. I believe that's a little different, but go ahead.
So yes, so I did say an OBOT, but there's actually two different varieties of OBOTs in general and specifically in Pennsylvania. The behavioral health OBOTs are highly regulated. They're governed by the by DDAP, and there's very strict requirements. There is physical health plans also cover OBOTs, and they have their own. They have a lot more latitude in how they want to contract with providers like us, and so we worked with our payers. I mean, this is perhaps a longer conversation, but they are very happy with our setup. We continue to pursue expanding our services, and so I'll say this one thing. I think that because we were primarily a network of medical providers in the past, and during the time of this pilot with WEconnect is when we were expanding to include some behavioral health services that are sort of embedded within a larger medical network. We paradoxically said that following the evidence, we do not require therapy, while simultaneously started providing therapy in-house, was, I think, part of why payers were very receptive to the enhancements that we were making as we continue to evolve our model. Yeah, there's the short version.
So technically, you're not a treatment center. Would that be correct?
This sort of slice and dices a lot of things, but we are not a licensed drug and alcohol provider. Yes, so in that sense, we're not a treatment center. We are by being a network of licensed providers. We are operating completely within Pennsylvania law, scope of practice, good practice standards, and but we have the latitude to evolve and create the treatment model that we think best suits our patients in real time. As we've seen this past year with COVID, the ability to move quickly is really helpful. We were already looking at a telehealth model for our patients because we were looking at the Ryan Haight Act and seeing that if there was a way that we could have provided telehealth before it was clear that this was it was clear from a federal legal standpoint. We were trying to prepare how we could provide more access more quickly. And then after COVID hit and everyone moved to telehealth, we were able to convert very rapidly. We already had some groundwork in place. I'm happy to say that over 70% of our patients are currently engaged through telehealth, and we found a clinical model that can adapt to that and is meeting those needs. So are we a treatment program in the common everyday sense that our patients would understand it? Yes. Are we a licensed drug and alcohol program? No.
Thank you so much for your clarification.
Sure.
Awesome stuff. Keep it up. And thank you so much. We'll see everyone back in the plenary session.
Thank you.
Take care. Can I close it out, Ashley?
You can hit your the top X. I'll take care of
Okay.
You're welcome.